All right, so good morning. We're going to talk about muscle relaxers and narcotics. What's the page number, just so people can know where to teach? 55? 55, page 55. This is a chapter that Mike Heller wrote, and I want to apologize on his behalf for sticking 40 frickin' abstracts for a half-hour talk. Okay, so that gives us approximately like 50 seconds per abstract. So we're not going to cover all the abstracts in detail. And I'm sure you don't want me to. I just want to make another disclaimer that most of this chapter is about muscle relaxants, which is probably a misnomer because they're really not muscle relaxants. And myself, I personally never prescribe these. I don't use any of these drugs myself, and a lot of them I can't even pronounce their names. The only time I prescribe them is if I absolutely can't get a patient out of the ED without prescribing them a short course of these things. And so, you know, you can know my bias right at the outset here against these drugs, and I'm sure that many of you share that bias. A lot of the papers in here, of all these 40 papers, are very old. There's some from the 70s, from the early 80s, and that's very relevant because most of these papers are inadequate to address the questions. They have small n's, small numbers of patients enrolled, which makes them unreliable. They almost uniformly, especially the old ones, have a weak methodology. One of the important reasons for that weak methodology, and that was typical of most papers at the time, is especially with respect to something so subjective like pain, we needed to develop standardized, validated measures for pain that were consistent across papers before we could start comparing things. I mean, you could prove just about anything by using different subjective papers in different papers. And if you combine that with the fact that the lion's share of these papers are simply funded and affected by the drug companies that are making the drugs to show that they're helpful, you've got really a cocktail for garbage. And that's what most of these papers are, really. And that's all the more reason for us not to go by them one by one, and we'll put them into groups. Another huge reason that there's a problem with interpreting this literature is what's called publication bias, and you all know that if the study is positive, it gets published. If the study doesn't show a benefit, it doesn't get published. And there certainly was no control over that for decades and decades. It's only recently that people that are at least doing substantial trials register these trials, so at least we know that the trial is going on and we can sort of follow up on the data. But at that time, there was no such thing. And so you have that sort of toxic combination of poor methodology, no standardized measurements for something incredibly subjective like pain, where you can basically say anything you want, and this publication bias. So these are really this is the reason why so many of these papers are problematic, and you don't have to worry about reading a paper from Clinical Therapeutics or Hospital Pharmacy from 1987. You just don't have to. I don't think it's a valuable use of any of your time, any of yours time. Now, which agents are we talking about here? The muscle relaxants, the so-called muscle relaxants, which really should be named CNS depressants, because that's what they are pharmacologically, are methylcarbamol, Robaxin. And this is interesting because we've got a mix of Canadians and Americans, and I always found it interesting how there's a different set of drugs used on both sides. You'll see that's a common theme. Like, for example, Soma, carisoprodol, I never heard of in Canada. We never used it, but it's a very commonly used thing here, and a lot of patients that I see are addicted to it. Paraflex, chlorioxazone or whatever, Paraflex, cyclobenzaprine, which is Flexeril, that's used on both sides of the border, or Phenedrin, which is Norflex. So those are and there's more. That's just a sampling of the big ones that we'll talk about. Then, of course, there's the benzos, which we don't talk about that much in this section. And then there's a little bit on the end, which I think you'll find interesting, a little bit of discussion about NSAIDs and Tylenol and narcotics, codeine and Vicodin. So those are the things we're going to talk about. So the first question is, do the muscle relaxants work at all? And you'll see in the first line there that Dr. Heller says, the literature says yes. Well, that may be true that the literature says yes, but I think I've just explained why, regardless of what the literature says, the real answer is likely no, that they don't work. We'll deal with two papers that we'll actually call out by number. That's abstracts 1 and 2. These are both meta-analyses that are separated by 23 years of publication. The first one is from Hospital Pharmacy from a fellow in Missouri, and he comes to the conclusion that the studies are all too flawed to make conclusions. And the second one is definite conclusions. And the second one in 2003 in Spine is a Dutch study which says that 77% of the studies are good quality. Now, it's true that the studies do improve in quality as time goes on, but the fact remains that 73% of those are industry involvement in those studies. Either they paid for the whole study, or the person who wrote the article is on the payroll of the drug company, that type of thing. And for me, that's enough. When you're dealing with a very sensitive thing like this where it's hard to get to the truth, that's enough to make me concerned about the validity of them. Both of those meta-analyses, as limited as they are, come up with the same conclusion, that there's only a marginal benefit of the muscle relaxants over placebo. They also come to the conclusion, which I think should also make you doubt some of the individual agents' efficacy, that no agent is really superior to one another. And this is another kicker, which is that they both conclude that these agents are really only effective at hastening recovery if they're combined with an analgesic, usually an NSAID, i.e. if they're combined with a drug that does something, which in this case is an anti-inflammatory analgesic. And NSAIDs, of course, are well acknowledged and well proven to be effective analgesics. All agents in this category are soporifics, which means they're sleeping pills, and they're limited by this important side effect. Okay, so even the studies themselves, which say that there is a marginal benefit, acknowledge just exactly how weak a situation this is. So that's that. Now, the next question that's posed here by Mike is, what about the elderly? Abstracts 3 and Abstracts 4. Abstract 4 is the better one. It actually deals with the emergency department setting. Talk about, and these are not experimental studies. These are not randomized controlled trials. These are basically descriptions of the incidence of inappropriate prescribing. And that inappropriate prescribing is defined by, in the second paper at least, the Beers criteria, which is basically just a group of experts, geriatricians on both sides of the Canadian-US border, that have sat down and said, what is appropriate to give, what drugs are appropriate to give the elderly. And I think you'll be interested. There's a lot of drugs on that list, and it's an interesting list for you to look through there. But you might notice that all of the drugs that I just listed in the category of muscle relaxants, they are all listed on that, in that group, which is to say that those experts, geriatricians, felt that that there were other drugs that were more efficacious and that were less potentially harmful that could be used in the elderly, which means that you should never prescribe those drugs in the elderly. So at least that might be valuable to you, maybe especially Abstract 4, because it sort of points out that none of these drugs should be used in the elderly, at least in the opinion of the experts, which have come to the same conclusion that I have on these drugs. If you look at that fourth abstract, you'll notice that gout and musculoskeletal problems were the most common diagnoses that were involved in inappropriate prescribing. But one thing that we might be able to take a little bit of heart of, I don't know if it really, I don't know, it's hard to know how they derived the numbers, but they said that 10.6% of the patients were on inappropriate drugs when they got there, but we as ER doctors only contributed 3.6%, so our rate of inappropriate prescribing was a little bit lower than they came in with. But then when we discharged them home, our rate of inappropriate prescription went up to 5.6, probably because they wouldn't go home unless we gave them their Flexeril or their Soma, that type of thing. So anyway, for what it's worth, experts think that these drugs are inappropriate for elderly people because their benefit is questionable and their side effects are real. I'm going to talk a little bit about each individual drug, but I'm not going to rehash these individual studies, these older studies, for the reasons that I went over. But there's a couple of interesting things that I would like to point out, and there's some interesting things that I learned doing this literature review and reviewing for this talk. The first one is, what about Flexeril? I love what Mike's description is in the first paragraph there, which is that most of us pretty much figure that these things are useless. We know they don't work, but they're pretty benign, and it's probably okay to give them for a few days so they can get to sleep. We were just talking before I got on here, and we were saying, I use these to put them to sleep with their back pain for a few days. And I know that it's not going to cure them or anything like that, but it's probably not a big deal. And that's probably what most of us feel, how most of us feel. But I just want to remind you that Flexeril is a cyclic antidepressant, okay, related to the tricyclic antidepressants, amitriptyline and nortriptyline. And we know that those are very dangerous drugs in overdose. And we know, anyone who's been practicing, say, 15 years or more, especially, knows just how horrible those drugs were. And so I see some heads nodding in the audience. I mean, those are the terrible drugs. I had a guy in my medical school class take an overdose of and die of it from TCAs. And those cases that I've seen come into the emergency department over the years, and this doesn't happen very much anymore. I saw one in the past year, but before that it had been several years. They're horrible. I mean, they come in, they look okay, but they're jittery at first, they're tachycardic, and then they have a seizure, and they aspirate, and then they go into cardiovascular collapse. I mean, it's a really horrible, horrible sequence of events. So one of the things I used to teach about Flexeril was, why would you prescribe a drug that we have a whole textbook chapter in our textbook about treating the toxicity for it? And you know it doesn't work. So why are you doing that? And so my impression was, hey, this is a dangerous drug. There's a couple of studies, though, that show that maybe I've overreacted a little bit in my teaching, and those are abstracts number 7 and 8. 5 and 6 are efficacy studies, so we're not going to deal with that. But in 7 and 8, there are two good studies that look at the toxicity of Flexeril. In the first one, abstract 7, they had 6,311 patients, and in all those patients, there were only 3 cases of toxicity noted, and they were all in the range of 260 to 900 milligrams. So what do you guys prescribe for Flexeril, right? 10 milligrams 3 times a day would be a typical dose. So that's pretty substantial overdoses, right? 260 to 900 milligrams were the range of those 3 cases. And in none of those cases were there any serious tricyclic effects. And you know, when we're talking about tricyclic effects, we're talking about, you know, seizures and cardiovascular collapse, hypotension, and dysrhythmias. And then in that second paper, abstract 8, they just described 402 pure Flexeril overdoses, mean of 184 milligrams. And all they saw is a lot of lethargy, a few comas, but no deaths, no life-threatening seizures or dysrhythmias. So that's pretty interesting. So maybe I overreacted a little bit about that. The other comment that is in there is that these overdoses were much worse in the elderly patients, much better tolerated by younger people than older people, which kind of goes in support of what we just discussed about how these drugs probably should be avoided in the elderly. So you might break down and give them, but maybe you shouldn't break down and give them to the patient who's 78 years old, 80 years old, that type of thing. Maybe that's probably a mistake. Maybe that's probably a mistake. I need to wake up. Okay, that is a mistake. Now, so in summary about Flexeril is, I think that, you know, maybe it's okay to give small courses of this. Make sure you know it's a cyclic antidepressant at least. And that not only is that important for overdose, it's also important for avoiding reactions. So for someone, for example, say someone's on a MAO inhibitor, you'd want to avoid it. If they're on another antidepressant drug, maybe it's a better idea to avoid it altogether as well, because you could precipitate what? Maybe serotonin syndrome, that type of thing. And I think it's good practice if you're going to give these not to give a whole bottle to people. Recognize that these are drugs of addiction, like most of the drugs in this category. And you know, if you want to give 6 pills to someone, 10 pills maybe maximum, that's probably reasonable. But I think when you start giving more than that, I think that that's probably, I wouldn't do it. I wouldn't recommend it. Does anyone have any questions or comments at this point? We'll move on to Soma. Yes?
Oh, no, I was going to ask more general questions. I'll wait.
Oh, okay, yeah. I think we're going to have time. I'm blowing through pretty quickly. So we're on abstract 9 now, and we're going to talk about Soma very briefly. This is another interesting thing that I want to point out to you. Again, I don't want to get into the efficacy of Soma. I think it's garbage. I don't think it works. But this drug has also something special that you need to know about it, which is that its metabolite is Miltown. You guys know Miltown? You know Miltown, right? You don't see it that much anymore. What's that? Miltown is a sedative hypnotic. It's in a different class from alcohol or from barbiturates, but it's another sedative hypnotic. Okay, there were a whole bunch of classes of sedative hypnotic. There was a whole bunch of classes of sed hips that have sort of fallen by the wayside. But there was a whole bunch. But you know, it's similar. It's similar to barbiturate in a lot of respects.
It was a headache pill back in the 60s.
It was also used for. It was also used as specifically for severe recurrent headaches. Okay, so exactly right. As were sometimes barbiturates, in fact. And the thing about this drug is that it, unlike what we were just saying about Flexeril, does seem to have a real nasty overdose potential. And it also has a nasty withdrawal symptom. Again, this is was more than it is now a common drug of abuse, and people would come in with withdrawal symptoms just like alcohol withdrawal, where they would need phenobarb and they would sometimes get intubated, and just like a bad DTer. Okay, so this drug actually has real danger potential. I have a friend who called me up a few years ago, and he was on shift, and he says, do you know what this drug is, Milltown? And I said, well, I think it's one of those old Seb hits. I don't know much about it. And I started looking it up in Tittenelli or something while he was talking. And he's like, well, I just sent someone home. They asked me to refill it. And that same shift, he called me back like an hour later saying, that same person I just wrote the prescription for just came in a coma. And they had just downed the whole thing. And it was a nasty case, and it got admitted to the ICU, and it was complicated. It's a bad drug. Anyway, so that was Milltown, and Soma is metabolized to Milltown. So, that's just one more reason, in addition to the ones that you probably are already using with your patients, as to why you shouldn't prescribe Soma. And again, the Canadians never know Soma. Like, I don't think that it exists in Canada, right? Okay, so there you have it. Now, what about Norflex? Well, it doesn't work either. Abstracts 10 to 15, all questionable studies. I like abstract number 15 because they're giving it IV. Which is kind of, I think, a little crazy. And they actually say that they think it works IV, but whatever. I just don't think that that's the case. Abstract number 15 is Parafon. Abstract number 16 is Robaxin. Basically, the bottom line, if you look through these and you actually comb through them, when you get past the bias, one of the common themes is they seem to work if you combine them with another drug that does, like NSAIDs. And that's sort of a common theme here. And all those papers have some sort of variation on that theme. The next question here, there's no abstract for it. But Mike points out, what about Scalaxin? That has to work. I mean, Scalaxin, it sounds like it must be a skeletal muscle relaxant. Again, there's no direct effect on the muscles that we know of. There's no reason for us to believe that it has any effect on muscles. It is, of course, like all the others, a CNS depressant. But what he points out here, and I wish we had done a better analysis on the overall cost of this category of drugs, but just Scalaxin alone, which, as you know, is not one of the heavy players here. I mean, I'm sure there's tons more Flexeril and Soma kicking around than there is Scalaxin. Just the cost, and this is not a historical thing. In 2007, sales rose by 14%, hitting $112 million US just for this thing, Scalaxin, which I don't think I've ever prescribed it or even seen it being prescribed. So just imagine the billions of dollars that's being invested in this category of medications. So I thought that was kind of a mind blower. Okay, so now we're getting to the end of that. We were at the end of that section on the so-called muscle relaxants. And the next section is about prescription narcotics. And there's a whole slew of abstracts here, all the way from 17 going forward into the 20s, about codeine. And this is really interesting, and we might have some north-south conversation about codeine. I bet you, I did my internship and I practiced for several years in Canada, and we used, when people came in with like abdominal pain, when we were thinking about an appy, that type of thing, we used to use 60 and 50, 60 of codeine and 50 of antihistamine. Which one do we use? Gravol, which in America is Dramamine. Right? So we used to use that as a standard combination. They still doing things like that? They're still using codeine like that? No? Okay. However, on the outpatient side, codeine in the form of Tylenol 3s is still a very prevalent drug in Canada, whereas in America, we still see Tylenol 3. It's not like we don't know what it is, but Vicodin is much more the currency the currency in which we deal. We're dealing in Vicodin. Yes, we're dealing in Vicodin, and the Canadians are still dealing a lot in Tylenol 3. And actually, I didn't really know the difference. I didn't really even, and we didn't use, and you guys don't use a lot of Vicodin, right? Or any Vicodin. You don't even have it.
Is that a hydrocodone?
And Percocet is different. Percocet's Oxycodone, and Vicodin is hydrocodone. So they haven't even heard of this drug, of course, which is the main currency besides the U.S. dollar in Los Angeles. And so, actually, besides the euro, it's the main currency. Yeah. So anyway, what's the deal here? And I didn't really know any of this stuff, but the literature is actually remarkably damning and consistently damning in paper after paper, dating right up to the current year, of codeine. Codeine adds little to analgesics. It adds little to Tylenol, and it adds little to NSAIDs. And I can say paracetamol for our one. Do we call it, in Australia, do they call it paracetamol? Okay, I just want to be, culturally sensitive. Yeah. So it adds little. It adds little to those in all of the studies. And those studies there from 17 onwards all say the same thing. The one thing about it is it appears to be limited by its side effects. When you get to the point with codeine into the sort of, at least 30 and usually 60 milligram range, when you start getting efficacy, because it is a narcotic and it hits the same receptors more or less as morphine and pethidine or Demerol, you start getting limited by the side effects, which are more prominent with codeine than they are for other narcotic analgesics. And that seems to be the thing that differentiates the narcotics more is their side effect profile. And they're mostly GI and CNS side effects. There's another issue with codeine that's unique to codeine, which is that 10 to 20% of the population, it does nothing. It has no efficacy at all because you know codeine isn't the active part of the analgesic. Codeine is not the opioid. It's converted to morphine. And about 10 to 20% of the people lack the pathways to convert it. And so there's people that are codeine non-responders genetically. And that's something that, for example, doesn't exist with morphine or with pethidine or Demerol, meperidine. And as you get older, activity increases. And so, and you know, it's interesting that you bring that up because codeine is even more unsuccessful in studies in children than it is in adults. And probably there's some, because some of those patients are perhaps more than 10 or 20% are not responding to it in children because of the enzymatic deficiency that gets better when you get older. So a couple of little things that I'll point out there that might be helpful to you. Abstract 17, just to sort of pile on to this elderly theme, shows that there's specifically a problem in the elderly as well as children, because in the elderly the side effects seem to be worse and limit them more. So that's abstract 17. If you're looking for a couple of articles that you might want to share with your colleagues if you're talking to them about this, abstract 25, which is by one of our colleagues, Sanjay Arora, is one of the two-page myths in emergency medicine section in the now defunct Western Journal of Medicine. So we've lost the Western Journal of Medicine. It's a sensitive topic. It was Jerry's journal. They wouldn't take any ads from drug companies, so it kind of went down. And God bless him. But the thing is that I just want you to know that we now have a new journal that we've started primarily at University of California, Irvine, and at our center, which is called the Western Journal of Emergency Medicine. It's the former California Journal of Emergency Medicine, and it's awesome. It's just in its infancy. It's in its first year, but we're getting a lot of great articles already, and I think you're going to see us come on the scene as a real player to join with the other journals like JEM. So watch out for that journal. Anyway, this myth section, they also have a great section in the Canadian Journal of Emergency Medicine, Myths in Emergency Medicine, that Mel Herbert used to be the editor of. And it's great because it's got these really concise evidence-based reviews of these common things that you always talking to colleagues about, yet it never seems that you produce a paper. Well, you can pull this one out and produce a paper when you're having the discussion of why Swadron told you that codeine sucks. Okay? So that one is abstract 25. Abstract 26 is a good quality paper in the British Medical Journal on Tylenol versus Tylenol with codeine, showing that there wasn't a huge difference in analgesia, but there was more side effects in the codeine group. And then for those of you that are in this Canadian-American dispute, which I'm going to try to keep neutral in, abstract 28 is the one you're looking for. That's the one in Annals in 1991 that showed that Vicodin was better than Tylenol 3s. So it does seem that Vicodin is a better drug. It doesn't have that problem of the enzyme limitation. It doesn't have the problem with the side effect profile that codeine has, and it appears to be a better analgesic. Yes, sir? Is there a liquid form of Vicodin? Yes. There's hydrocodone available as liquid in different preparations with and without Tylenol. There's a whole slew of preparations, and some of them are listed at the end of this chapter. So that's great, and you can use it in kids as well as you can, just as well as you can Tylenol 3. Okay, so that's good. So just in summary, I'll get your question in a second. So just in summary, codeine appears to be limited, and it's especially limited in the young and in the old. Question. We're getting to that. Yeah. I love it, man. You're one step ahead of us. Now, the next issue is I just wanted you to take a look at abstract 29 for a second. And the reason I want you to take a look at abstract 29 is it's kind of typical of a lot of the research in this particular area. And I pick it to highlight because it's a 2007 paper. It just came out. And we're almost on time, Jerry, so I'll be done in I think 3 minutes. So take a look at that paper for a second. This is actually Canadian, okay? And it's from Children's Hospital of Eastern Ontario, CHEO. And the kids in this pain study have acute musculoskeletal pain, not fractures, but something short of that. And the kids are 6 years of age to 17 years of age, okay? And they're comparing three things here. They're comparing a group that has codeine, a group that gets Tylenol or paracetamol, and a group that gets ibuprofen, okay? And the reason I want to point it out to you is because it's just so typical of these studies. And last year we did a whole chapter just on this, on the Tylenol versus ibuprofen controversy. But look at the doses they give. They give 15 milligrams per kilogram of the Tylenol, okay? And they give a maximum of 650 milligrams. So you get like these 17-year-old kids, right, that are like, on the Eastern Ontario football teams. I don't know if they actually had. We weren't allowed to do football when we were in Ontario. But anyway, that was an American thing, right? We were only allowed to do basketball. Probably too much liability. But the thing is that you got these big kids, they could be 200 pounds, and they're going to max them out at 2 regular strength Tylenol. That's the dose they're going to allow for comparison, 650 milligrams. When clearly they need more. Clearly they need at least 2 extra strength Tylenols, right? They need a good dose of Tylenol to be fairly compared. And just so many of the studies, there's hundreds of them, and they all use these suboptimal doses of acetaminophen. And so it's a big problem. On the other hand, you look at the group that gets the ibuprofen, and they use it 10 milligrams per kilogram, and they're allowed to max out at 600 milligrams. And so, most of us believe, most of the experts in this field that know a lot more than I believe, that there's a ceiling of the analgesic effect of the NSAIDs, perhaps at 400 milligrams or so. After that, you get more anti-inflammatory effects, so for disease-specific things like rheumatoid arthritis. But there's some analgesia, and they're allowed to go to that ceiling and beyond. So you've got this ridiculous comparison going on. And even then, the benefit of the ibuprofen over the Tylenol is not that great. So I'm pointing this out to you more to show you what the main flaws in this type of literature are. I think that probably there's not a huge difference between these two analgesics, and of course one is a lot safer than the other. Tylenol, with its huge therapeutic index of safety, where you can give many times the recommended doses and still be safe, especially in kids where it doesn't seem to matter how much Tylenol you give them, they seem to recover, even if there is some hepatic necrosis. And ibuprofen, which it's a good drug, it's a very good drug, but it does have a higher side effect profile, and there's a lot of contraindications that we need to be aware of. I think you should be careful in diabetics with it because it's decrease of blood flow to the kidney. You got to be careful with the stomach. And there's some other things there's some other less common things with ibuprofen that Tylenol doesn't have to worry about. So overall, I think Tylenol is probably a better drug. So I just wanted to point that out to you. Codeine, of course, in this study gets totally, look at it. It does even worse than the Tylenol. So again, just heaping this more grief on the codeine. This is really interesting, Jerry, because we've got Tylenol 3 abusers and Vicodin abusers in the same room here. So, and I've been in both camps myself. Now, this is really interesting. Abstract number 30, I had no idea. This is my favorite paper in this section, okay? This is a paper, where is this one? From Denver General, back in the 80s, in JEM. I love this paper because they have people that are constipated from narcotics, okay? And they gave them intravenous Narcan, 0.8 milligrams to 1.2 milligrams, and this is the greatest, and they said, it promptly reversed the situation. I think that they were being polite, which is to mean they had huge craps, and Code Brown was called. And so I don't dispute their findings. I believe them when they say that the situation was promptly relieved. Yeah. It doesn't say anything about this, but anyway, that's definitely the coolest article there, because I'm definitely going to try that. I think probably the same thing applies. You're not supposed to give someone who's high on narcotics, you're not supposed to give them a huge whack of 2 milligrams of Narcan, right? They're gonna get up and they're gonna punch you out and take you down. I think probably the same thing is true in this case. You probably don't want to give 2 milligrams push to someone who's constipated, because you might have a similar conflict between yourself and the patient. Anyway, that's the best paper in there by far. Okay, now this abstracts 31 and 32 talk about oxycodone and hydrocodone. So that's what you guys were getting at. What's the difference? The difference is this Vicodin versus Percocet. You know what? Those papers, I actually pulled the papers to look at them. Neither of them, I think, are good enough to actually answer that question. So I think you can ignore that. I don't know if one is better than the other. I really don't. My suspicion is that in just looking at their pharmacological profile, they're very similar. And so I don't think that we can make a meaningful comment on that like we did about codeine and Vicodin. And then we have to talk just briefly about Ultram. That's abstracts 33 through 36. Okay, this is important, okay? I've never prescribed Ultram, okay, just for the record. And this is a very popular drug, and I don't know the numbers here, but I'm curious to know how many hundreds of millions of dollars this thing is costing us. Every study on this shows that it's not very effective. It might be equal in efficacy to Tylenol or to ibuprofen, but no better. And that's something that's consistent across many papers. Okay? What is clear is that it has more side effects. It causes more GI side effects, but not just mild side effects. It also has reports of cardiotoxicity. It has reports of seizures with it. Okay? Not only that, but it's a drug. What is it? It's a partial opiate agonist. Okay? It's a partial. It's like an agonist-antagonist. This is not the first one. There have been others. Okay, Propoxyphene's another example. We've never liked those drugs, and they've never been popular among the pain experts. In OD, they're miserable, and this is something actually a practical benefit. Partial agonists, when you need to reverse them, might not reverse fully with Narcan because of their mechanism of action. These are the ones where you might give 2 of Narcan, and you might need to give another 2, and you might need to give another 2. I think that's helpful to know. The other one that's like that is fentanyl, not because it's a partial agonist, but because it's so potent that it often takes more than 2 milligrams to reverse it. And I've seen that so many times myself that I feel pretty comfortable telling you that. But anyway, so it's nasty in overdose, and it causes bad overdoses. Not only that, but it interacts with the serotonergic drugs. So you could be taking that with dextromethorphan or cocaine, which a lot of our patients take, or with a tricyclic, or with a serotonin drug, and precipitate serotonin syndrome, if that wasn't enough. So all these wonderful benefits of the drug, and then you add that to the fact that, of course, it's very expensive, you've got yourself a situation that is hard to understand. Why is it that we're prescribing this drug? And yet, I'm seeing it very commonly. And I'm seeing it, frankly, out of the pain clinic as well. And I'm not sure why that's happening. But our pain clinic is prescribing this to people they're trying to get off other drugs. And so I don't know what that's all about. But this drug appears to be useless and dangerous. The last articles there speak to the issue that the gentleman brought up, which is, does codeine work for cough? No. Does dextromethorphan work for cough? No. And then article number 40, abstract number 40, points out that honey is more effective. That's wonderful. Circle that one. That's from 2007. So I think Rick alluded to that yesterday. And then abstract number 41 points out the primary use of dextromethorphan, which is as an emerging drug of abuse among our youth. And then Mike gives you all kinds of interesting information about that in the CDC website. So it doesn't appear that we've gotten anything that works too terrifically for cough. Maybe honey. I don't know. Yes, sir. For the botulism thing? That's an excellent question. I don't think I know the answer to that question. I think the issue isn't necessarily, I think the issue is the hygiene issues and making sure that you sterilize the bottles and all that kind of stuff. But I'm actually not sure about that, so I'm not going to pretend I know. At what age are you okay with the honey? I don't know. You know about that, right? Because is it, you've heard 1 year? Okay. Okay, so that's the second most common cause of botulism in the United States, and I suspect it's probably the same in Canada. The most common cause is wound botulism. Wound botulism. Oh, no, actually, I think I have that reversed. That's the most common cause of botulism. There's like 75 cases reported where was an infant botulism, and some of those are from honey. You know, you put the kid to sleep with the honey on the bottle, that type of thing. And then the second most common cause is wound botulism. So those are the 2 biggest causes of botulism, even though we all read about the canning process and all that kind of stuff. That's actually number 3. Yeah.
I find that if I'm trying to treat what I think is muscle spasm in the ER, I usually use a benzo.
Yeah.
Is that, am I just sedating the
Yeah.
patients?
Yeah, and we didn't, and there's not a lot of papers here about the benzos, but benzos are CNS depressants, and that appears to be their primary mode of action. Again, I think that most of the things that we said, even though we didn't have the papers here, that we said about the other drugs, probably it's reasonable to apply to benzos. And I'm concerned about benzos in any long-term use situation, and I think that probably on average, if you look at benzo prescribing patterns in the United States, I think it's pretty clear that we're doing far more harm than we are good with those drugs. So I better, okay, one more question, and then we'll get to it. Hydrocodone, right. Yeah, well, hydrocodone doesn't work for coughing, and that other drug that I have trouble pronouncing, guaifenesin, right? As an expectorant, it's an expectorant. It's a mucolytic expectorant that also doesn't work. Okay, so I mean, there's a combination of 2 things that don't work, and so I'm not so upset that they've taken it off the market. I mean, we got a lot of problems in this section here. A lot of stuff that doesn't work. That's a good question. I mean, yeah, like if there's a reactive airways component, which there so often is, then I think it's reasonable to try albuterol. But I think also you can be honest with people, you know, and tell them we don't have a lot of good medicines for this. The side effects. Yeah.